Okay, so welcome to Eat, Move, Think, the show about optimal wellness brought to you by Medcan.
Wow. Do it again.
Oh, I was practicing.
Okay, ready?
Welcome
to
Eat, Move, Think,
the show about
optimal wellness
brought to you by
Medcan.
Yeah, this is extremely good. Thank you.
Jazz, can I try out a metaphor on you?
I love metaphors. Let's do it.
Okay. Preventive health and wellness is a detective story.
Ooh.
It's about investigating clues to find culprits that will cause health problems down the road. So cardiovascular disease, diabetes, atherosclerosis. It's all about an investigation ferreting out clues. And this episode is about the finding of a new clue that takes the investigation in a whole new direction.
Way to sneak that Only Murders in the Building reference in there. I'm Jazz.
I'm Chris.
We're the producers of Eat, Move, Think.
Well, let's break down this metaphor a little bit.
Yeah. Let's figure out what we're talking about here. We're talking about hs-Troponin.
Great.
Yes.
That's the new clue. What's interesting about hs-Troponin?
hs-Troponin is a direct correlator to your risk for cardiovascular disease in the future.
And what is it? Like, is it a...
It's a protein.
Oh, it's a protein.
In
Okay.
your body, and the indicator is depending on how much was in your body last time you did a blood test. It's all about the trend. So even if you feel fine, you're super fit, you look great, you could be at really high risk for a disease or for a condition, for a heart attack down the road, angina, something like that. And you don't necessarily know that until you can arm yourself with a test like hs-Troponin.
So there's electrocardiogram, there's exercise stress tests. What's new about this one?
It's a simple blood test. That's what's special about it. It doesn't take any more time than you're already spending doing that blood test that's already looking for so many other things.
And then also it's able to find risk of cardiovascular disease earlier than other types of tests.
A lot of the time research like this is developed and it might take years for it to actually make a difference in patients' lives. So this episode is about the way Medcan made sure that didn't happen.
Walking us through the importance of troponin, and specifically this hs-Troponin test, is our wellness host, Dr. Peter Nord, the Chief Medical Officer at Medcan.
He's in conversation with Tricia Ravalico. She's the Director of Global Scientific Leadership and Education at Abbott, the U.S. medical devices and healthcare company responsible for developing the hs-Troponin test and for bringing it to Medcan.
Amazing. Here's Dr. Peter Nord.
Well, hi again, Eat, Move, Think listeners. I'm Dr. Peter Nord. Delighted today to welcome to the episode Tricia Ravalico. How are you doing today, Tricia?
I'm doing great. Thanks, Peter. Happy to be here.
That's great. Yeah, it's been an exciting and a challenging time. We're going to talk today about cardiovascular disease and specifically troponin. And, the challenge of preventative health is all about catching illness early and early enough that you can actually do something about it. Like it's one thing to say, well, we found something, but if it's too late, you're not really adding a lot of value. Today, we're going to focus on moving the bar as far forward as possible in terms of picking up things early. And obviously, the earlier we catch something, the better the prognosis tends to be. And that's just better for everybody. And we've been thinking about this for quite some time at Medcan. Until recently, though, the early detection we've realized is okay, but it can be also a little problematic when it comes to cardiovascular disease, which is the second leading cause of death in Canada and North America. And a lot of that is because we've basically used testing like cholesterol levels as one of the main markers of risk, and other things have been kind of late in the game as opposed to getting and moving the prevention opportunities earlier and earlier. What are your thoughts on that, Tricia?
Well, I couldn't agree with you more in terms of the importance of prevention, right? Cardiovascular disease is a huge global burden. And I think we've all experienced either friends or family members with a major event, right? So it's scary. Right? It's potentially fatal. And really with the advances, we see a lot of patients surviving heart attacks, which is great news, but it only ends up leading to potentially heart failure, which is irreversible, can be debilitating, and can impact quality of life, right? And the question really is, what are the tools in the arsenal that allow us to early identify risk and then modify that risk? As part of a manufacturing world, our mission has always been to find that perfect surrogate, right? That has sensitivity for finding the right patients and specificity. So you're not, over treating patients that may not need that care. When we think of cardiovascular disease in the pathophysiology, the more we go earlier, a lot of the biomarkers that exist that had great promise in research end up becoming a bit more complicated when it hits prime time. And that's because it's not always specific to the heart. And so the challenge really becomes, in a non-perfect world, how do we identify this early with enough specificity and sensitivity that we are managing the correct patients well?
Great. I'm glad you brought that up. We can certainly, dig into that a little bit more. And in a more general sense, assessing cardiovascular risk has been imperfect, as you hinted there. And we're really thinking about, future states where we can be using all sorts of different markers. And there's some exciting stuff on the horizon that we can bring to bear. The problem is that, we have used historically things like an electrocardiogram or an exercise stress test. The exercise stress test, when it starts to become positive, for the most part, you already have a 50% narrowing in your coronary arteries. And the options for fixing that are really minimal. You can maybe stop the progression. And then once that happens, then on the electrocardiogram, we can pick up the fact that, one of those squiggles isn't in the right spot. And we can pick up if there is a lack of oxygen, or frankly, even if there's a dead spot in the heart, we can pick that up on the electrocardiogram. So using these sort of tests is really imperfect.
Yeah.
It's a done deal at that point. And then secondary prevention. Okay, now you've got some plaque buildup in your coronary arteries. We can reduce your blood pressure with medicines. And now we're talking about pills and medications. And that's not great. We'd love to have people, living long and living healthy. So that idea of lifespan and health span as well. So that quality and quantity of life. And we've missed the boat if we're using those sort of tests. Maybe we can talk a little bit about some of the other tests that have been out there. And I know you've continued to look at through your role at Abbott in terms of like the high sensitivity C-reactive protein. One of the things we do at Medcan is CIMT, which is an ultrasound of the carotids to look at if we start to see thickening of the walls of the carotids before there's actually a plaque buildup. It's better than a stress test, but it's still not the best in terms of screening tests. And then there's things like ApoB and LP little a, lipoprotein small little a. Other tests that you're looking at and have looked at over the last number of years?
We're always looking at cardiac biomarker tests, usually focusing in, just as you described, that earlier paradigm of what biomarkers exist, like even placental growth factor for predicting plaque rupture, plaque instability, inflammation, as you mentioned, with high sensitive CRP. That's a acute biomarker of inflammation, which is outstanding because it's, sort of an early risk predictor. And small acute levels, right, are actually indicative of cardiac risk, but not specific to the heart, right? And so this is where, sort of a repertoire of a lot of testing and multiplexing really has come in. And we've done a lot of studies in that area. And I know we're going to talk about troponin later, but, when troponin was thought to be once a marker of necrosis, exclusively necrosis and irreversible heart cell death, what was the adjunct biomarker that's going to provide enough specific and sensitive information that would help advance the diagnosis or the detection or the level of risk? It's kind of ironic that, as we sort of transgress or evolved, we started to appreciate that, even what we learned from troponin has evolved with time.
Yeah. Well, let's talk a little bit about troponin. People may have actually heard of troponin because it's come into more standard utilization over the last 10 years or so. Maybe you can give us a little bit of background on the troponin in general, and then how you started to think about the high sensitivity troponin and kind of the work that Abbott did in validating some of that high sense troponin.
Oh, fantastic. Yeah, I mean, I'm a huge fan of this protein, right? It's integral to all muscle contractions. And it's very special because there's an isoform of troponin called cardiac troponin that is heart specific. And for decades, really, after we, first introduced troponin or understood its power as a biomarker or a surrogate for heart cell death, we started to recognize that, increased levels, as you describe, actually correlated to patients that were experiencing more and more heart injury. And so with that, in the early phases, it was very clearly diagnostic for, having heart cell death. And when you could measure it through a blood test, we could start to recognize these patients were possibly experiencing a heart event. Interestingly, and the reason why you said serial measurements is it's actually how you diagnose a heart attack, is looking for that change or that rise and or fall. Classically, these tests were somewhat insensitive though, right? And so the thresholds were traditionally quite high. And so the push for manufacturers at the time was really in acute settings to see how can we more reliably continue to get, the answers in a very precise way. Because when you're talking about a heart attack and to differentiate a chronic case, you're really looking for a rise and or a fall. And so the more precise the tests are, the more accurate you know that the differences that you're seeing are pathological and not analytical due to the tests themselves. So there was this huge push for manufacturers to develop more precise testing. And that's really when we talk about high sensitivity troponin, what we're talking about. So high sensitivity troponin is not a different protein. It's essentially a descriptor of a methodology or a test method capability or next generation of troponin tests, if you will, that have such precise detection capabilities that now we can detect very minute levels of troponin with very high degrees of accuracy. And therein lies huge potential. And it became a game changer, both in the acute setting and opened huge doors for prevention. So the why is previously, as we mentioned, for so long we had associated with heart cell death, irreversible heart cell death. And we didn't really know that healthy individuals had circulating amounts of their troponin. We just simply couldn't see it. This whole Gaussian distribution was almost invisible based on our process capability from a test perspective. And then as we developed these new tests to be more accurate, what we learned is that they were more sensitive. We could measure troponin now in almost 100% of all healthy individuals, which means there's a baseline level of healthy cell turnover that we could leverage with accuracy to now fill the gap, that surrogate gap that we were speaking about earlier. The perfect biomarker is A, diagnostic, B, prognostic, which means, the elevations increase with disease severity, and modifiable. And I think that last piece, and it trends with treatment. And I think we'll speak to that in terms of the actionability associated with risk prediction. So once we had, the ability to test more people with circulating amounts of troponin in the acute setting, right, for patients that present with chest pain, you were able to do those serial measurements sooner, which was a game changer in many cases for health systems, certainly hospitals. But on top of that, we started to recognize, and there's large population-based trials that show this, that now these subacute elevations, much lower than thresholds traditionally used for heart attacks, are very, very prognostic and in fact trend with patients' physiology in such a way that it enlightens and really creates awareness and insights that are game changers from prevention.
Yeah, super exciting when you start to see that. Just to give a sense to the listeners, when you say high sensitivity troponin versus traditional troponin, what's the scale there? How small of a unit are we measuring at the high sense versus troponin, sort of a blunt instrument versus the more high sensitivity?
Yeah, just for perspective, when we talk about troponin with the contemporary assays, we're talking about 2 decimal points, right? Like 0.05 and whatnot, 0.26, et cetera. So we're talking about nanograms per liter. And now imagine everything being 100-fold more sensitive. So now there's no decimal points, in fact, right? Now we can talk about whole numbers. So these whole numbers that we're seeing and we're measuring used to be in the noise level of the previous generation of assays. A common term is the 99th percentile, right? Like 99% of all people will be below a certain number. Now we're talking about, for females, maybe about 15, 16, for males, somewhere around 30, almost double the normal range of women. And now as we transition that thought into prevention, sex-specific cutoffs still play a massive role, but now we're talking about very small numbers like, 5, 6, 10, et cetera.
Yeah, that's great. And our experience so far with high sensitivity troponin is that we're picking up people that have disease and have no idea. And that's also where the game changer comes in, where the goal really is to take all those things, and diagnostic, prognostic, modifiable, in a population of people that are essentially asymptomatic. have no idea that something's brewing.
I couldn't agree with you more. How we feel and what might be happening inside of our bodies in terms of early onset of disease aren't always connected. And we have this perception, maybe because of our traditional thought process associated with cholesterol and our lipid profiles, that you have to be obese to be at risk for a heart attack. And the truth of the matter is, it's not always, how much plaque you have. It's if it's unstable, and you could be very fit, maybe even be a marathon runner, and you're not free from the burden, if you will, of cardiovascular disease. And so having a biomarker, a simple blood test that objectively really gives you a good status or predictor of your current and future risk is huge. And then, as you said, since most people, particularly young people, right, have levels around 1, 2, we're talking about very small amounts. If we see a rise over time, that is very prognostic because we know the tests are accurate. We know they're very precise. And so we know that the differences that we're seeing over time, whether it's moving up or whether it's moving down, is suggesting a trend related to the status of that patient's risk.
Yeah, that's a really interesting takeaway as well, because I know sometimes when I'm with patients, I'll talk about the fact that over time, trend may be more important than even the absolute number. And that can be for something like even a PSA. So we might get a PSA that is under the limit that we say, hey, you're fine. But if we look back over the last couple of years, we can see that it's actually increasing steadily. And so at what point do you kind of raise the red flag? And if I'm seeing a trend line that still might be below a threshold of worry, but if the trend line's going in the wrong direction, it's almost just a matter of time. Why should we wait for that to become a real problem? Let's try and intervene as early as possible. We're lucky. We're on a given year, we're going to have 20,000 people come through for their annual health assessment. A lot of those people are going to be having now an hs-Troponin. It could be normal, but if we look back over the years, we actually could start to see a rise in that hs-Troponin that it would be worrisome and something we could then be, even though they're in the normal range, maybe we throw the red flag up and kind of go, maybe this is something we need to dig in a little bit farther.
I couldn't agree with you more. In fact, I think the cardiovascular annual health assessments at Medcan are a game changer for the population. The ability to have serial measurements annually, which you have, speaks to personalized medicine. Looking at what patients' levels of cardiovascular risk look like relative to the patient's risk they had the year prior, right? And it's not necessarily exclusively relative to a threshold that may or may not be predictive or an accurate threshold to look at. When thresholds are defined, and we talked about this when we talked about the 99th percentile, it's population based, right? But what is so much more special is when you can actually compare your risk levels to your own risk levels from the previous year. Troponin levels can increase with age, right? And so having that comparator to yourself, being able to look at that, which is what everyone can do at Medcan, is honestly insights that aren't always, really had in other settings.
Yeah, and then maybe we can start a treatment or a therapeutic regime. It could be something as simple as exercise, diet, all the things that we'd be thinking about from a cardiovascular perspective, control the blood pressure, stop smoking, watch the salt, all those sort of standard approaches, and then watch over time as that hs-Troponin starts to decrease.
Yeah.
So it's indicative on the way up, and it's also reassuring on the way down, measuring the benefit of a therapeutic plan.
Oh, absolutely. And I, especially as patients become more engaged in their own health, having something that's tangible, right? That they can see that their numbers are changing and they're going in the right direction is just validation that the things that they're doing, whether it's going out and getting a walk or reducing their salt intake or all the different, eating better, these do make a difference. And in fact, it's proven, right? We've seen that those patients that reduce their troponin by 50% or, are being more athletic in how they attack their everyday life, if even walking for 30 minutes makes a difference. And it shows that improvement to heart health, something that we've always known, but now we have, evidence even as we go. So it's not, have to wait 10, 20 years. We can see that if they've made lifestyle changes within a year, you can see that.
Yeah, the history of hs-Troponin at Abbott goes back a number of years, many years. The history of hs-Troponin at Medcan goes back almost exactly 2 years. I think it was probably 2 years, almost to the month. We were just a bit opportunistic. We're always looking for the latest in terms of these sort of biomarkers that we can bring to our population. It was spurred really by the pandemic. And at the end of the day, because of aerosolization and the risk to staff and to other clients, we really couldn't do exercise stress testing. I mean, most people were really staying away from any kind of testing that involved heavy breathing. We knew that the virus was highly aerosolized under those sort of situations. And so we just couldn't do it. And yet we were still having to offer the annual health assessment. We had many, many people, thousands of people that were still looking to us to keep a finger on the pulse of their health, maybe even more so because of the pandemic. And they were having difficulty accessing care. And so it was just fortuitous that we found each other, and hs-Troponin was going to fit that bill because it was something that could take the place of, and in fact, as it's turned out, much better than exercise stress testing. And it also afforded us an opportunity to have a bit of a clean break and to do some research and analysis and look at as you said, the sensitivity and specificity of exercise stress testing for a large population. It turned out that the latest research was showing it was not great. It was good, but not great. And we discovered hs-Troponin, and it seemed like it was something that we just had to do. And so through our partnership, it was something that we did a bit of a pilot initially. It seemed like it was going really well. And then as we started to look at that, we started to pull up and said, well, okay, if we're going to look at this hs-Troponin versus exercise stress testing, what else should we be looking at? And is there other benefits? And certainly time saving. There's the irritation to the patient potentially of having to go through the stress test. And to our providers, our physicians and other clinicians, what was the impact on them? And so we were starting to look at this, and then you brought up there's sort of a global competition called Univance. And before we dive into some of our findings, maybe you could just give an overview about Univance.
Oh, sure. I'd love to. The Univance of Healthcare Excellence Program is a global award. It began about 5 years ago, and it's recognized as one of the most prestigious honors across healthcare teams today. It recognizes healthcare teams who have unified across disciplines, work together and leverage laboratory data, so insights from laboratory medicine, to change care pathways and to achieve outcomes for patients, payers, clinicians, and health systems. So impact the entire ecosystem of care in a measurably impactful way. The program's been in existence, like I said, from before COVID. But what's interesting is that we've found that even though COVID created, I would say, a little bit of chaos in the health system environment, it also facilitated some of the barriers that existed related to change, right? And I think you spoke about the fortuitous opportunity that you had around that time, is that challenges end up creating opportunities. Even during the COVID times where I would expect maybe applications to perhaps go down, we actually saw an increase in applications globally. So there's about 170 countries engaged in the program. The judge organizations are from all faceted, like leading societies across the world. So Abbott funds the award, but we have no role in the judging process. But when we see good health innovation, right, when we actually speak to teams, and I do that, as part of my job regularly across the globe, particularly when we see novel approaches to really impact large scale health in the space of prevention, in the space of even chronic diseases, the application process is actually pretty straightforward if people have metrics that quantify value, right? And that's, Peter, where you and I met some time ago, because I was so intrigued and pleased and really honored to even have the opportunity to review some of the metrics that Medcan has been achieving across a lot of the areas that we discussed and will likely get into. I want to highlight that one of the highest honors with the award is recognition of distinction, and Medcan received recognition of distinction with the 2021 program. And it is a highly prestigious, beautiful honor that only really the elite top get recognized. And this year, I believe there were 13 sites total, only 3 that got recognized in the space of distinction, and Medcan was one of them. So Peter, if I haven't said it already today, a huge congratulations to you and your entire Medcan staff, because I know it takes a village. It received such honors because of the outcomes that have been generated. So, I know we'll dig deeper into that, but, congratulations again.
Oh, thanks, Tricia. Yeah, no, it was really exciting. And as you said, it took a team within Medcan, and your team also were instrumental in getting us to understand what Univance was looking for. And it just so happened that the research we were doing seemed to align pretty well. We did have a great outcome. And some of those things that we found, I kind of summarize it: saving time, saving money, but most importantly, saving lives. So in terms of saving time, moving from a stress test to the hs-Troponin ended up saving each of our clients 38 minutes. So it's 38 minutes less of the day. And obviously we've already spoken to the benefit from a sensitivity and specificity perspective.
I'm sorry to interrupt, but I just have to say, I get excited when I can get off a call maybe 5 minutes earlier, because that's 5 minutes, 10 minutes of my day. So that's a significant benefit, right? These clients that you have, and there's 20,000 or more, right? If each of them are saving, over 30 minutes of their day, getting more information, equal information, if not more information, that is significant. It is huge, right? And I imagine that, as a potential client, right, I see that as a huge, huge benefit.
Yeah. And also saving time for our physicians too. It's another one of our, great stakeholder populations that we want to focus on. And because the physicians with exercise stress testing have to review the results. And those typically, as it turned out, when we did the analysis, took about 10 minutes. And if our average day, a physician's going to see about 6 people, 6 times 10, that's an hour of the physician's time as well. They can do lots of other things with that hour. That turns into more counseling time, more time with the patient to review their results, or potentially even see another patient. So rather than, seeing 6, maybe we can move to seeing 7 in the day, because we've literally saved an hour. And in terms of saving money, we looked at the false positive rate associated with exercise stress testing, and we looked at what happens to those people. So they go on to further testing. And when we put a number to that, sort of what the average stress test false positive rate is times the number of people that we were seeing, and then the kind of testing that essentially then is unnecessary. And the cost of that, obviously, there is more than just the dollars and cents, because it's people's time and worry and stress associated with further testing. To our public health system, it saved almost $400,000 a year in unnecessary testing. So saves money for sure.
Yep.
Also, in terms of saving money, we had staff that we could repurpose into other, again, value add aspects of the day. And then even just during the 6 months that we were doing the data collection, we picked up 48 healthy individuals, again, subclinical, asymptomatic people that ended up having significant elevations on their hs-Troponin that we sent directly to urgent cardiovascular follow-up. Many of those people went on to have bypasses, stents put in. They had unknowingly, because these people, they could be fit, they could be in other ways healthy. And yet when it came right down to the hs-Troponin, it was the one thing that said, hey, something is really going sideways here. Sent them to the Emerge, sent them to the hospital. Those are 100% life saved. 50% of all individuals, their first symptom of cardiovascular disease is sudden death. It isn't necessarily that gradual onset of angina. These are people that are walking around and suddenly just have sudden death. And that's something we just have to avoid. And this was almost 50 people that could have been in that situation. If numbers were true, half of those 50 might have had sudden death as their first symptom of cardiovascular disease.
Really, that's the holy grail right there. I mean, these are people clients that are presenting for a wellness test, right? So if that doesn't speak to the fact that, they're health enthusiasts, right? They care about prevention, they care about their health, they want to know what's happening. they're asymptomatic, and they're finding out something that changed their life, potentially saved their life, as you described. So, that to me, for everyone out there, like that just reminds us, to have our health assessments done, to do this annually. When we think of healthcare, so often we think of diagnostics as scary, right? Because it's telling us if we have a disease, and it's associated with, maybe finding out that we might. But as we start moving towards sick care, right, this transactional, maybe cold situation, and start really appreciating the power of these annual health assessments and prevention, I see biomarkers and a lot of these measures as our friend, right? This is something that's either telling us we're doing great, right? Or suggesting we need to do things differently in a way that's actually going to prevent sudden death, any type of, cardiovascular complication or other complication, even outside of CVD. So, those numbers to me are not only fascinating and really personal, but really, really impressive. And when something new comes out, like something like a game changer like hs-Troponin, it can be difficult to get that adoption and to actually drive change. It's difficult for us to change, right? It's difficult for me to sometimes get motivated to exercise and all these other things. When you're talking about changing behaviors of physicians who are ordering tests or whatnot, it can become complex and sometimes slow. And this is where I think the pandemic, coupled with this great innovation, really were the best timing of all. In the time of need where you needed to fill this gap, became the opportunistic opportunity to really almost 100% go straight into the testing. And then what I loved about what Medcan did is you really had a pulse not only on the physician value, but really what do patients want? What are your clients asking for? And so I really loved even some of the outcomes associated with, whether your patients were experiencing or noticing change. And by doing so, you actually educated clients on what troponin was. And I see that being as a major change, right? As we all become champions of our own health, as we all look for prevention, these are game-changing health assessments with game-changing biomarkers included, like hs-Troponin, that make a difference.
And we have now got almost 2 years experience with that. So it's been a great run. It's been one of those tests that, at the end of the day, it's just one more test that we add to the series of biomarkers that we're collecting from people's blood samples. And there's some exciting longitudinal research that we're going to be applying, looking at this and other biomarkers, because as you mentioned, we have this unique population of 20,000 people, many of whom come back to us on an annual basis. And over time, that presents a very interesting research opportunity. So we're very excited about leveraging the kind of data that we're gathering, which, because of our volume, is on the scale of some other countries. Like a whole country's data in some parts of the world are generating, similar kind of numbers to what we're doing just through Medcan. So I'm really excited about the future, and so much of that excitement is based on our experience historically, just generally, but more specifically, most recently with hs-Troponin. So, thanks to you and your team for doing the legwork to really do the research, to be committed to the kind of healthcare innovation that we're needing more so now than ever. And not just because of pandemic, but, the health system's in disarray, and we really do need to be looking for these kind of innovations that just make a ton of sense. And so it's been a great experience for us. And the Univance Award was just sort of the icing on the cake, kind of a nice capstone or a validation of the kind of work that the team was doing. So super excited by all of this, looking forward to working together in the future on other tests that are like this. I wanted to thank our listeners for joining. Again, I'm Dr. Peter Nord, Chief Medical Officer at Medcan, and I've been talking with Tricia Ravalico. Stay well, everyone.
Bye.
That was Dr. Peter Nord in conversation with Tricia Ravalico, the Director of Global Scientific Leadership and Education at Abbott, the U.S. medical devices and healthcare company. The hs-Troponin test, which we explored in this episode, is a key component of Medcan's annual health assessment. To book an annual health assessment, call 416-350-3621 or email clientservice, clientservice @medcan.com.
Follow Medcan on Twitter and Instagram at MedcanLiveWell.
We'll post episode highlights and links you can visit on our website at eatmovethinkpodcast.com. Say hello and send send us a tip or a suggestion by emailing us at info@eatmovethinkpodcast.com.
Eat Move Think is produced by Ghost Bureau. I'm Jasmine Ratch, a managing producer. Social media and strategy support is from Chantel Gertin, Andrew Imex, and Emily Bosick.
Executive producer is me, Christopher Shulgin. We'll be back soon with a new episode examining the latest in health and wellness.
This podcast is intended to provide general information about health and wellness only and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation or endorsement. The links provided within the associated document are to assist the reader with the specific information highlighted. Any third-party links are not endorsed by Medcan.